Hello and welcome to the GIRFT webinar to launch the Getting It Right First Time programme. I'm Garrett Fuller, I'm the clinical lead for GIRFT Neurology, and I'm looking very much forward to sharing with you some of the insights that we've got from the GIRFT report. A few points of housekeeping. The webinar is being recorded, so you'll be able to view it again at your pleasure. And if you have questions or you'd like to make any comments, if you could put them in the question and answer slot, and we will be dealing with that later on. In this meeting, I'm joined by Kath Mummery, the chair of the Services Committee from the ABN, who will be presenting after me, and Georgina Carr, who's the Chief Executive of the Neurological Alliance. And on the panel, we have the chair of the CRG, Adrian Williams, who hopefully will be able to provide other insights when we join the panel. Now, I'm hopeful that everyone is pretty familiar with the idea of getting it right first time. Now, this was an initiative that was launched by Tim Briggs in orthopedics and has really been transformative in many of the other specialties where it has been undertaken, allowing people to realize and recognize variation, clinically important recognition of problems, and as a result, improved outcomes for patients. And obviously it's now been spread out across a whole range of different specialties, and we're now going to consider neurology. Now, the first thing to recognize is variation versus unwarranted variation. Now, within neurology, as we'll see, there is a vast amount of variation. And the key thing is to recognize what is unwarranted variation and what is unwarranted variation that is clinically important and that we could perhaps try and amend to try and improve patient services. And I'm going to talk briefly about the different types of hospital site that are developed, introduce the idea of the neuroscience region that most people will perhaps be familiar with, and then I'll go through the various patient journeys that we've used as the basis of our report, acute admissions and a referral to outpatients, patients with chronic neurological disease and those requiring specialist care. At your registration, you had to indicate whether you'd read the report, and the only other option you were given was that you'd not yet read the report. So hopefully you'll be able to flesh out many of these thoughts in detail as you read the report in full. Finally, we'll touch on some conclusions. So broadly speaking, looking at a hospital, you can't really be sure exactly what services it provides, but broadly speaking, there are 5 different sorts of hospitals in relation to the neurology services that they provide. We have 24 neuroscience centres, which is the sites where there are neurosurgeons and neurology, and they're 24, and generally speaking, these have been the focus of the neuroscience regions and have a whole series of linked hospitals. And of the linked DGHs, a number, 27 across the country, have become neurology centres. So they're DGHs that have provided inpatient services as well as outpatient services. And then there are a number of DGH neurology centres where neurologists are based, and then there are a number of sites, DGH sites, where neurology services are provided by people coming from other places. There are still a number of sites, though fortunately the number has fallen as we've gone through our visits, where no neurology services are provided. And this is the distribution of these different centres across the country, and you can see substantial variation. The purple crosses are the neuroscience centres, and you can see they're scattered across the country. And you can see some sites, some parts of the country, so for example, the Peninsula or the Southwest, you have linked services in neurology centres, and you have other places such as Liverpool or Manchester, where you have a very strong hub and spoke system where everyone is at the centre and spread out. And if you then look at the distribution of consultant neurologists across different regions, you can see there's really quite marked variation. And you can see that not just that numbers are different, but the way in which they're allocated or the way in which they're distributed is different. And so you can see there are quite a number of hub and spoke centres where you see everyone is employed by the neuroscience centre. And then you've got other places where you've got a mixture between neurology centres in the purple, in the orange, and neuroscience centres in the blue. And then you have what we've referred to as interlinked regions, where you have neurologists based at N3 sites, so there's neurology centres, DGH centres and neuroscience centres. So we can see from this that there's marked variation in consultant numbers between different regions, and that's reflected by the services they're able to offer. And there's quite marked variation in the organisation of those regions. Now, one of the factors that's contributed to that, and I think is the kind of variation that is worth being aware of, is the variation in spend from the specialised commissioning. And you can see that there's huge variation in spend according to where you live, rather than necessarily the problems that you have. And this reflects the fact that the funding is based on a service delivery at N1 sites, and there's quite marked variation in spending according to specialised commissioning. So let's get back to our patients. And our first patient is somebody who's admitted through the acute medical take. And to look and find out what's happened to them, we haven't focused on the patients that neurologists see specifically, but rather what happens to people who are discharged with a primary diagnosis of a neurological disease. And this cohort has been further enriched by categorizing diagnoses as those that we feel would definitely do better with neurological involvement, probably, possibly, and rarely. And we've used this cohort to allow us to make comparisons between the activity at different sites. And what you can see, first of all, is that a bit under a quarter of these patients are admitted to a neuroscience centre, about a sixth at a neurology centre, but 2/3 of these patients across the country are admitted to sites that do not have inpatient neurology beds. So 64% do not have inpatient neurological beds. So most people are not admitted to a site with neurology beds. And does that reflect the fact that the diseases are different? Well, actually, if you look at the distribution between these different categories, definitely, probably, possibly, and rarely across different types of hospital, they're broadly the same. So the range of discharge diagnosis is the same regardless of where you're admitted. And if we look across the whole spectrum of different sites, what we can see is that the larger hospitals tend to be places which have inpatient beds, and not only inpatient beds. The light blue colours are the ones where there are inpatient beds. You can still see some quite small trusts having patient beds. And the number of patients under neurology, which is actually the darker colour, you can see, again, varies considerably between one site and another. So we've got all sites admitting, admittedly, typically the larger ones, and a quite marked variation with the proportion who are under neurology. So let's just consider what happens to that 64%, the majority of people who are getting admitted with a neurological disease. And they'll be admitted and they'll go to the acute medical unit and then to the general medical ward, and they will be referred to a visiting or a neurologist based there who will give an opinion, what we've referred to as liaison neurology. And this is the main mechanism where inpatients will get an opinion, and this is not recorded and is not specifically funded. And what you find is if you look at sites where DGH sites, 80% of those which are N3 sites have a 5-day service, and at the N4 sites, which is 20% or so of the population, the average is 3 days a week. So remarkable variation here, something which is echoing findings that have been previously demonstrated by the ABN Acute Neurology Service. A number of sites have done different things to try and improve this, and patients can be referred to an acute neurology clinic, something which actually tries to take quite a proportion of patients out of the system and actually prevent admissions where possible. Some of the sites have developed a proactive liaison neurology service where they've visited acute medical units daily to try and find patients and provide advice before they've actually gone further on in the journey. A number of sites have managed to cohort patients with neurological problems to a limited number of sites, sometimes actually running an inpatient neurology MDT, where there's actually an attempt to emulate inpatient neurology without actually having the final step. And this is obviously enhanced if you can have a junior doctor attached to it. And so we can do these different things to try and improve matters. Neuroradiology links and vary, and some DGHs have managed to get neuroradiology MDTs regularly, and that's been described as transformative where it's achieved. And clearly now people are working remotely, that can be facilitated by distant Teams-based meetings. Access to neurophysiology, as we'll touch on a bit later, is a significant issue. So obviously what could do is that it could aim to try and transform these centres to a neurology centre, which is broadly what's happened in lots of other, so essentially at all the sites that have become neurology centres. And what happens at a neurology centre and at a basic neuroscience centre is that the patients, typically speaking, will have access to an acute neurology clinic, about 3/4 of the sites, but also if they have a neurological problem, they can get under a neurologist. They can actually get access to those specialist care. And what's needed to achieve that? Well, a lot of the time, one of the issues is junior staffing, and the other is access to neurophysiology, both of which seem important to develop a neurology centre. Does it make a difference? Well, if you look at those patients who have definite or probable conditions, and if you're at a neuroscience centre, 42% end up being under a neurologist. At a neurology centre, 26%, but if you look at that same cohort of patients who are admitted to other sites, only 1.5% get transferred to one or other of these sites to be able to be under a neurologist. So the likelihood of being under a neurological team depends not on what's wrong with you, but where you are admitted. As we've visited sites, we've met some sites, some neuroscience centres that have developed really extraordinarily sophisticated and excellent services in acute neurology for the patients that are admitted there. So for this minority of patients who attend there. And some have got an acute neurology service where most patients are transferred through to the neurology ward. Some sites have a hyperacute neurology service where pretty much everyone is going straight from general practice through A&E. They're not involving the general physicians at all, but are going straight to the neurology world. And one or two of these sites are also looking after stroke as well. So we have a few sites where there's really quite marvellous acute neurology services that we would all hope that we could emulate. And neurology centres typically have a 7-day service. For a liaison neurology, most neurology centres typically only have a 5-day service. But obviously the problem here is that we can't emulate the excellence that's being achieved in a very limited number of sites. And the reason we can't do that is illustrated here. And what you can see again, this is now looking at non-elective patients who are in for slightly longer. And what we can see here is 28% of these of the population of these patients are admitted to a neuroscience centre, and yet they have 80% of the junior doctors, 80% of the registrars, and 58% of the consultants. Admittedly, they're likely to be covering this patient group here. So we can't move on to this model because of the imbalance in staffing mechanisms. It's interesting to see that the neurology centres, broadly speaking, have junior staff levels that reflect the population that they look after. Is it related to the number of neurologists? Well, it isn't, because actually it seems, if you look at the number of consultants per population, it doesn't seem to correlate. So the involvement in acute neurology is not just related to the number of neurologists. And is it related to the size of the hospital? Well, this is now looking at the number of stroke admissions and the number of non-elective neurology admissions. And you can see the largest sites mainly have inpatients, but not all of them. And then there's this fairly large number of sites with significant inpatient where it's very variable. And if one just does the sums, what you find is that if you took only all hospitals in the largest quartile, you would require an extra 23 neurology centres, so in other words, DGH neurology centres turning into neurology centres, and this would then cover close to 60%. And if you took the largest 50% of the hospitals, you'd be covering 72%. Now, clearly that could be further improved if you were engaged in pre-hospital triage. So our second patient journey, before COVID, we found that pretty much everywhere, every outpatient service is stretched, some to a very dramatic degree. And the question is, how can one try and improve that? And some of the initiatives like triage and advice and guidance have been actually accelerated with COVID, where people have been trying to deal with patients' problems remotely where possible. Clearly addressing the DNA rates is an issue, and thinking about how to optimize follow-up using other staff and different strategies is a way forward. Just to highlight a few of those issues, what you can see here is the distribution of outpatient activity according to different CCGs, and you can see it varies very markedly and typically matches the distribution of consultants, the same for follow-ups. And we've got this marked variation, but actually one of the problems with drilling down into outpatient activity is the fact that it's not really coded in a way that we would like. You've got no coding by diagnosis. Some sites will code neurology nurses separately from consultants, and in the regions where everyone's employed by one site, everything is counted as if it's happening at the neuroscience centre when it isn't. So just to reflect on the acute neurology service, the outpatient neurology service, are there ways to try and make it quicker? Well, this is the tradition that we've got where patients will be referred. It takes quite a long time to get people through. A lot of the time you can make a diagnosis from the letter or provide specific advice. And if you do this, then you can actually get the treatment started in days. Clearly, if you have a triage system that can identify these patients, you can actually track people and improve the clinical access. And advice and guidance seems to be being more widely taken up and has been over the last few years. And there's little doubt that active triage of referrals with an ability to respond to referrals can reduce the number of patients who actually need an appointment by between 10 and 25%. To make this work, you do need GPs to have access to investigations. The DNA rate is very markedly variable, and clearly if you could reduce this, this would produce a substantial improvement in access. Neurophysiology, just a couple of comments in relation to this. First of all, this is showing the number of appointments by different CCGs, and you can see by different neuroscience regions, and you can see really quite a marked variation. And the variation isn't just between regions, it's also between different sites. So if you're at a neurology or neuroscience site, centre, you've got pretty much everyone has neurophysiology, but if you're at one of the others, about half of them do. And clearly, access to neurophysiology is going to be an important element in the diagnosis and management of many of our patients. Now, with patients with chronic neurological disease, there's so many different diseases, it's inevitable that one just picks out a few particular issues. We're very keen that services should be developed and delivered as close to the patient's home as is feasible, and that the patients should be supported by advanced clinical practitioners or specialist nurses where possible. And ideally, these will be integrated into neurology teams, and we would have argued for credentializing their training to improve the consistency and the skills of the advanced clinical practitioners. And generally speaking, we recognize there's not going to be a vast increase in the number of people, so it's really a question of making sure that the members of staff are all doing things at the best of their abilities. So what a specialist nurse can do, a neurologist shouldn't be doing, and so on. What administration and that sort of thing shouldn't be being done by a specialist nurse, it should be done by an administration support assistant. So this is just to highlight the variation in neurology specialist nurses, and you can see it varies enormously, with quite large parts of the country not having access to that. And this is reflected in really the remarkable variation in the distribution of prescription of valproate to women with childbearing age. And you can see there's a six-fold variation here. And clearly this is something very significant given the risks of heterogeneity attached to that. This is looking at the MS disease-modifying therapies, and clearly all the neurology and neuroscience centres are delivering it, but crucially, they're also being delivered at quite a wide range of different DGH centres of one sort or another. And the crucial thing is that these patients don't have to travel the distance that they would have to. And clearly in some of the regions, that was making a difference to the choice of medications patients were using. The main barrier here was the commissioning rules, and clearly they need to be adapted to allow patients to be given these treatments locally with appropriate support. Likewise, Botox is a regular treatment and it's very variable, and a lot of patients would have to travel quite significant distances. But some sites demonstrated that you could actually have a visiting service to be able to do this on a weekly or fortnightly or even monthly treatment so to provide a service at a small hospital. So just thinking about the patient journey for the highly specialized care. Now, this is a small number of patients, and a lot of the time, actually, it is beyond a single region. So we need to be thinking about things at a slightly different level. And this is illustrated perhaps by the fact that half of all epilepsy surgery done is done at 5 sites, and 65% of deep brain stimulation is done at 4 sites. So this is something where the regional organization is actually not high enough. We'll touch on how to attach that. And Adrian Williams has been leading the NHS service transformation team, looking at different patient pathways to try and look at these links. And links between regions and how they're established is going to be important. So, broadly speaking, we've got a large number of patients who are seen locally, and we want to be able to deliver as many of these services locally. Now, there clearly is a regional input, but a lot of the time this needs to be now a networked rather than a specifically delivered. And the idea would be that for common diseases like MS, epilepsy and Parkinson's, the centre of gravity would very clearly be locally, with perhaps integrated team coming to visit them. I think one has to recognise that sometimes there's an opportunity for even super specialist areas. So, for example, the National Neuromyelitis Optica team runs clinics around the country to support local clinicians in delivering care to their patients. And I think this is a model that can be spun out for quite a wide range of different conditions. So how can we make the changes? Well, we've been visiting all the various centres, and there's an implementation team to try and help people go through the recommendations. We needed to understand and support people in trying to develop neurology centres from DGH sites. The model hospital is being updated to be able to provide some dashboard to give you in-time, real-time information about the service that you're providing. And I think one of the ways forward is the integrated care systems, which is going to provide a population-based service or population-based perspective on commissioning. And I think it provides an opportunity to facilitate inter-trust cooperation, which I think has been limited in some parts of the country. And changing the rules and changing the way in which commissioning organises is going to help facilitate that. So what would a population-based service look like? Well, you'd have an acute service on the lines that we described, and it may not be at every site, but you would expect it to be available within each of the population sites. You'd have an outpatient service with an appropriate set of links to other services. You'd have an elective service to be able to deliver these things locally to patients within an appropriate clinical governance framework. And you'd have links with a super specialist and the super regional services. So what have we done? Well, this has all allowed us to understand what we're doing at the moment. It's illustrated what can be done, and some of our colleagues have been very successful in the transformations that they've made. And we've obviously allowed us to share these kind of insights, which is obviously part of what we're doing. And you could characterize all of this as leveling up, though I'm slightly loath to use the phrase. There are many people to thank. I'd like to highlight particularly the help and support we've had from the ABN Neurological Alliance and the CRG at the NHS of England, and particularly all the neurologists who've been so welcoming and so positive in their contributions to our discussion. And I'm grateful for my colleagues at Gloucester for putting up with me.